Cardiovascular function. Chapter 23, this is for pathophysiology, structure and function of the cardiovascular and lymphatic system. So, when we're talking about the heart, we're talking about the right side of the heart. We're thinking about pulmonary circulation that moves through the lungs, creates a link with the gas exchange function of the respiratory system. So when we're talking the right side of the heart, we're talking pulmonary arteries, pulmonary capillaries, pulmonary veins. When we're talking the left side of the heart, we're thinking systemic circulation, which moves blood throughout all of the tissues of the body. And when we're thinking of the left side of the heart, we're thinking of the aorta and its branches, the capillaries that supply the brain and the peripheral tissues, the systemic venous system, the vena cava, which empties into the heart. Here's just a good pictorial of looking at the circulatory system so you can see how the blood flows and how it's oxygenated and not oxygenated. So when we're talking about the heart, we're going to talk about the heart wall and the mediastinum. And so when we're talking about this, we're talking about the three layers enclosed in the pericardium. There's the epicardium, which is the outer layer, the myocardium, which is composed of cardiac muscles, the endocardium, which is that inner lining. So then we go into the pericardium, where we have the pericardial sac, and it has three main functions. It prevents displacement of the heart during gravitational acceleration or deceleration. It serves as a physical barrier to protect the heart against infection and inflammation coming from the lungs and pleural space, and contains pain receptors and mechanoreceptors that cause reflex changes in blood pressure and heart rate. The two layers of the pericardium, that the parietal and the visceral pericardia, are separated by a fluid containing space called the pericardial cavity. The pericardial fluid is about 20 ml, is secreted by cells of the mesothelial layer of the pericardium and lubricates the membranes that line the pericardial cavity, enabling them to slide smoothly over one another with minimal friction as the heart beats. The amount and character of the pericardial fluid are altered if the pericardium is inflamed. When we're talking about the chambers of the heart, there's four chambers. There's the right atrium, left atrium, right ventricle, left ventricle. We have four valves. The atrioventricular valves are the tricuspid valve and the mitral valve. Our semiluminary valves are the pulmonic supraluminary valve and the aortic supraluminary valve. This is just a really nice detailed picture of all the chambers and where the valves are and the arteries in the heart and the veins. So when we're talking about the atrioventricular valves, we're talking about the tricuspid valve and the mitral valve. And then we're talking about the pulmonic and the aortic valves. So when we're talking about blood flow and cardiac cycle, each ventricle contracts and the relaxation that follows it constitutes one cardiac cycle. During that period of relaxation, termed diastole, blood fills the ventricles. The ventricle contracts, that follows that term is systole, propels the blood out of the ventricle and into the pulmonary and systemic circulation. Contraction of the left ventricle occurs slightly just slightly before the right ventricle. Contraction, I'm sorry about that. The 5 phases of the cardiac cycle are said to begin with the opening of the mitral and tricuspid valves and the atrial contraction. Closing of the mitral and tricuspid valves as passive ventricular filling begins, marks, and ends of one cardiac cycle. So the heart is capable of generating and conducting its own electrical impulses. So an ECG can measure and record these electrical impulses. The conduction system consists of the SA node, where the rhythmic impulse is made. Internodal pathway, which is conducted the impulse from the SA node to the AV node. The AV node impulse is from the atria, is delayed before passing to the ventricles. The AV node, which conducts the impulse from the atria to the ventricles. The left and right bundles of the Purkinje system conducts impulses to all parts of the ventricles. So structures that control the heart action. So the propagation of the cardiac action potential is the electrical impulse through the myocardium. The muscle fibers of the myocardium are electrically coupled so that the action potential passes from cell to cell rapidly and efficiently. The resting membrane's potential of the myocardial cell is between 80 and 90 millivolts, whereas the SA node is between 50 and 60 millivolts, and the AVO, the AV node, is between 60 and 70 millivolts. During depolarization, the inside of the cell becomes less negatively charged. Depolarization is electrical activation of the muscle cells and is caused by the movement of ions, including sodium, potassium, calcium, and chloride, across the cardiac cell membrane. Deactivation of cell repolarization occurs the same way if circumscribed. If the resting membrane potential becomes more negative because of a decrease in the extracellular potassium concentration, it is termed hyperpolarization, a refractory period during which no new cardiac action potential can be initiated by a stimulus follows depolarization. The electrocardiogram. So an electrocardiogram originates from the myocardial cell electrical activity as recorded by skin electrodes and is the summation of the cardiac action potential. So the PR interval is a measurement of time from the onset of the atrial activation to the onset of the ventricular activation. The P wave represents atrial depolarization. The QRS complex represents the sum of all ventricular muscle cells depolarization. During the ST interval, the entire ventricular myocardium during the ST interval, we're looking at the entire ventricular myocardium. The QT interval is sometimes called the electrical systole of the ventricles. So the T wave represents ventricular repolarization. Automaticity, or the property of generating spontaneous depolarization to the threshold, engages the SA and AV nodes to generate cardiac action potentials without any external stimulus. Rhythmicity is the regular generation of an action potential by the heart's conduction system. The SA node sets the pace because normally it has the fastest rate. The SA node depolarizes spontaneously 60 to 100 times per minute. Sodium, potassium, and calcium are the major ion charge carried in the cardiac muscle cells. Cardiac output. The efficiency and work of the heart is often determined by cardiac output, which is the amount of the blood that pumps out the heart each minute. So C out equals SV times HR. So your preload is the volume/pressure inside the ventricle at the end of dystole. Your left ventricular and diastolic volume. Laplace law states that the wall tension generated in the wall of the ventricle to produce a given intraventricular ventricle pressure depends directly on ventricle wall thickness. Your Frank-Starling law of the heart indicates that the volume of the blood in the heart at the end of dystole as the volume determines the length of its muscle fibers is directly related to the force of contraction during the next systole. Afterload is the resistance to eject the blood from the left ventricle. The load muscle must move after it starts to contract, and it's determined by the system vascular resistance in the aorta. So blood flow depends on sufficient blood volume to fill the vessels and provide a force that is needed to move the blood. The arteries and arterioles function as the distribution center and have the highest pressure. The capillaries link the arterial function as the distribution center and have the highest pressure. The capillaries link the arterial and venous side of the circulation. They serve as an exchange system to transfer gases, nutrients, and waste, and contain the smallest amount of blood because of their size and surface areas. The venules and veins contain the largest amount of blood and function as a reservoir to collect blood from the capillaries and return it to the heart. Okay, so the vascular endothelium is important to several body functions and is sometimes considered a separate endocrine organ. Blood supply depends on endothelial cells, which forms the lining or the endothelium of the blood vessels. It actually forms a smooth lining of the blood vessels that resists clot formation, and it creates a compound to promote clot formation in injured areas. It has food and oxygen pass into the tissue. Waste and CO2 pass from the tissue into the blood, and it creates growth factors that can stimulate and vasoconstrict smooth muscles. Factors that influence blood flow include pressure, resistance, velocity, turbulent versus lamellar flow, and compliance, with the most important of these being pressure and resistance. Resistance is the opposition to blood flow. Most opposition to blood flow results from the diameter and the length of the vessels. The change in blood flow through an organ results from changes in the vascular resistance within the organ because of increases or decreases in vessel diameter. Postural law indicates that the resistance is directly related to tube length and blood viscosity and inversely related to the radius of the tube to the fourth power. So greater the resistance, the lower the blood flow will be. Velocity is spread in the distance blood travels in a unit of time, usually centimeters per second. Laminar versus turbulent flow. Blood flowing through the vessels, except where the vessels split or branch, is usually laminar. In laminar flow, concentric layers of molecules move straight ahead, with each layer flowing at a slightly different velocity. Where flow is obstructed, the vessels turn or blood flows over rough surfaces. The following becomes turbulent with whirls or eddy currents that produce noise, causing murmurs to be heard on auscultation. Resistance increases with turbulence, which frequently occurs in areas with atherosclerotic plaque. Vascular compliance is the increase in volume a vessel can accommodate for a given increase in pressure. Compliance depends on factors related to the nature of the vessel wall, such as the ratio of elastic fibers to muscle fibers in the wall. Compliance determines a vessel's response to pressure changes. Arterial blood pressure is determined by the cardiac output multiplied by the peripheral resistance. The mean arterial pressure, which is the average pressure in the arteries throughout the cardiac system, depends on the elastic properties of the arterial wall and the mean volume of the blood in the arterial system. The cardiac output of the heart can be changed by alterations in heart rate, stroke volume, or both. An increase in cardiac output without a decrease in peripheral resistance will cause a mean arterial pressure and flow rates to increase. Total peripheral resistance depends not only on characteristics of individual vessels, but also depends on only on characteristics of individual vessels, but also on whether the vessels are arranged in a series or in parallel, and on the total cross-section area of the system. So if they're parallel, they offer less resistance. There is also an effect of hormones. So we have different hormones such as epinephrine, which is a catecholamine. That hormone is released from the adrenal medulla, and it causes vasoconstriction in most of the vascular beds, except coronary, liver, and skeletal muscle circulation. We also have norepinephrine, which mainly acts as a neurotransmitter. However, it can be released from the adrenal medulla and released into circulation, and it is more potent. It's more potent of a vasoconstrictor than epinephrine is. And then we also have these natriuretic peptides or hormones, and there's a variety of them, and they can increase diastolic volume, increase pressure or diastolic volume in the heart by stimulating the release of these peptide hormones. Alterations of cardiovascular function. So, chronic venous insufficiency. Varicose veins typically involve the saphenous veins of the leg and are caused by trauma to the saphenous veins that damage one or more valves or radial venous, one or more valves, and then you get this gradual venous distension caused by the action of the gravity of the blood in the leg. Chronic venous insufficiency is inadequate venous return over a long period of time. And then we can get venous hypertension, circulatory stasis, and tissue hypoxia caused by inflammatory reaction in the vessels and tissue leading to fibrosclerotic remodeling of the skin, and then it ends up, they get these ulcerations. Sometimes you will see that with that secondary to the impaired blood flow, the tissue will get congested, edema, impairment of the tissue nutrition. They get necrosis. They get sub-Q fat deposits. The skin gets atrophied. They get this brown pigment. They can get dermatitis and venous stasis ulcers. Treatment can be everything from elevating legs to wearing compression stockings, physical exercise. You can also have more invasive management, meaning endovenous ablation, sclerotherapy, surgical ligation, where they can do actual vein resection or vein stripping, and some skin grafting can even need to be done. So venous thrombosis is a blood clot that remains attached to a vessel wall. And deep vein thrombosis occurs primarily in the lower extremities. And you can get that from venous stasis, which is the immobility. And it could be from age, it can be from congestive heart failure, it could be due to trauma, intravenous medications, hypercoagulable state, inherited disorders, malnutrition, pregnancy, use of oral contraceptions, or hormonal replacement can all cause this venous stasis. Venous thrombosis, when we get that presence of that thrombus in the vein with an accompanying inflammatory response, it's most common in lower economics. It is a serious disorder, and it can be complicated by a PE, which obviously is a blood clot that goes to your lungs. And when we're talking about the triad-diverse-Shao, is stasis of the blood, is increased blood coagulability, and vessel wall injury. Risks include bed rest, immobility, impairment of cardiac function, cancer, trauma, lifestyle, drugs. And you'll see an increase in swelling, erythema, and you want to use strategies to prevent DVTs when you're seeing these. And the script is to prevent formation of additional thrombi and the extension of embolus with anticoagulants, especially when they're in bed rest and elastic support. So when we're talking about hypertension, this affects 70 million Americans. It leads to coronary artery disease, myocardial infarctions, heart failure, and stroke. So why in hypertension does the heart have to work harder than normal to pump the blood to all the parts of the body? It's part due to the vasoconstriction that increases in afterload. Because of this vasoconstriction, renal blood flow decreases, resulting in an appropriate activation of renin, angiotensin, aldosterone systems. So it leads to a lot of issues on down when we're dealing with this. It is one of the most prevented chronic health disease conditions in the U.S. It is also categorized by primary or secondary. So secondary would be caused by medications such as birth control pills, hormone replacement, antihistamines, decongestants, and glucosteroids. We classify prehypertension as 120 to 140 or 163 and 80/89. Um, so when we're looking at this, diagnosis is usually made um, when we have a blood pressure of 140 or greater and diastolic pressure of 90 or greater. Um, and so we want to make sure that we get more than one reading that's elevated to make this diagnosis. So primary hypertension is the result of an extremely complicated interaction of genetics and environment mediated by a host of neurohumoral effects. It's essential or idiopathic hypertension is another name for it. It affects 90 to 95% of individuals with hypertension. And we're going to see risk factors such as high sodium intake, natriuretic peptide abnormalities, inflammation, obesity, insulin resistance, all play a factor with this. The sympathetic nervous system has been implicated in both the development and the maintenance of elevated blood pressure and plays a role in hypertensive end organ damage. Increased SNS activity causes increased heart rate and systemic vasoconstriction, thus raising the blood pressure. So in hypertensive individuals, overactivity of the RAAS contributes to salt and water retention and increased vascular resistance. High levels of angiotensin II contribute to endothelial dysfunction, insulting resistance, and platelet aggregation, and play an important role in the complications associated with the metabolic syndrome. Angiotensin II mediates arterial remodeling, which is structural changes in the vessel walls causing peripheral resistance. Natriuretic peptides modulate renal sodium excretion and require adequate potassium, calcium, and magnesium to properly function. The natriuretic hormones include atrial natriuretic peptides, B-type natriuretic peptide, C-type natriuretic peptide, and urodilatation. I said that wrong. Sorry, urodilatin. They're along with alterations in the RRA system and the SNS causes an increase in vascular tone and a shift in the pressure. Will cause this naturalizes relationship. When there is an inadequate neuroretic function, serum levels of the neuroretic peptides are increased in hypertension. Then there is a link to the ventricular hypertrophy, atherosclerosis, and heart failure. So hypertension is usually asymptomatic. When symptoms do occur, they usually will have target organ damage, such as kidney, heart, eyes, blood vessels. They're at risk for atherosclerosis. They are diagnosed by repeat blood pressure measurements over different days. And treatment is usually lifestyle modification, meaning decreased salt, exercise, weight loss, and pharmacological treatments. So orthostatic hypotension or postural hypotension is decrease in systolic blood pressure of at least 20 millimeters, or a decrease in diastolic blood pressure of at least 10 within 3 minutes of moving to a standing position. It can be acute, which is caused when a normal regulatory mechanisms are sluggish or as a result of altered body chemistry, drug action, antihypertensive, antidepressants, prolonged immobility caused by illness, starvation, physical exhaustion, any condition that produces volume depletion, or any condition that results in venous pooling. Chronic orthostatic hypotension may be a secondary to a specific disease or idiopathic or primary. The disease that causes secondary orthostatic hypotension are endocrine disorders, metabolic disorders, or disorders of the central or peripheral nervous system, cardiovascular in persons with diabetes, and is a serious and often overlooked complication. There usually is a 500 to 700 milliliter shift fluid momentarily shift when this is occurring. Symptoms can include dizziness, syncope, or both. They may have some blurred vision. It's diagnosed by doing serial blood pressures in the different positions and also a tilt table test. The script is to eliminate the underlying cause, drug therapy, increased fluid, salt intake. Sometimes we'll use the thigh-high compression stockings, mineralocorticoids, and vasoconstrictors. So, an aneurysm is a local dilatation or outpatching of a vessel wall or cardiac chamber. True aneurysms involve all three layers of the arterial wall and are best described as a weakening of the vessel wall. Most are fusiform or circumferential, whereas saccular aneurysms are basically spherical in shape. False aneurysms is an extravascular hematoma that communicates with the intravascular space. A common cause of this type of lesion is a leak between a vascular graft and a natural artery. An aorta is most susceptible, especially abdominal, and it can causes include atherosclerosis, hypertension. If somebody's a smoker, that can cause it, and it can lead to aortic dissection or rupture. An aortic aneurysm can involve any part of the aorta. They can have multiple aneurysms may be present. Clinical manifestations depend on where the aneurysm is located. Most aortic aneurysms are asymptomatic until they rupture, and they can cause severe pain and hypotension while they're rupturing. Thoracic aneurysms can cause dysphagia and dyspnea. So abdominal aortic aneurysms develop after the age of 50, are more common in men, associated with atherosclerosis. They usually are most commonly located at the level of the renal artery. And most AAAs are asymptomatic. They may have a pulsing mass, and that may be their first evidence of the disorder. They usually are discovered during routine ultrasound, CT, or MRI, and it's just usually accidental that they find them. The risks include thrombosis, PE, erosion of vertebrae, compression of the lumbar nerve. Depending on where it's located as to how they can also fix it. Dissecting aneurysm is an acute life-threatening condition, and it involves a hemorrhage into the vessel wall with longitudinal tearing. Most are of the ascending aorta and between the ages of 40 and 60 in men, more prevalent if they have hypertension and deregulation of the medial layer of the vessel wall. When we have somebody with AAA, we're going to be monitoring the size of that aneurysm. Usually it'll be yearly, but once they hit a certain size, then it's every 6 months. And then when they hit a certain size, then it is going to be fixed. If it can be fixed where we go through the groin and fix it that way and laparoscopically, that's the way to fix it. An open abdominal aneurysm repair is a huge surgery, and sometimes will keep us from being able to fix it is where it's located by that renal artery. If they can't get around to, or if it's too right there at that junction of the renal artery, they can't fix it using laparoscopically with the grain repair. And then they can't do the synthetic graft. That way they have to do open. And it can be a huge, huge surgery. And it in itself has lots of complications and is no guarantee that they're going to do well and get out of the hospital right away. So, thrombus and embolism. As in venous thrombus, arterial thrombi tend to develop where intravascular conditions promote activation of coagulation and when there is a stasis of blood flow. Conditions include surgery, procedures, inflammation, traumatic injury, infection, low blood pressure, or obstructions that cause blood stasis and pooling. Embolism is the obstruction of a vessel by an embolus, a bolus of matter circulating in the bloodstream. No matter how tiny it is, an embolus will eventually lodge in a systemic or pulmonary vessel determined by its source. Pulmonary emboli originate on the venous side, mostly from deep veins of the legs of the systemic circulation or in the right heart. Arterial emboli most commonly originate in the left heart and are associated with thrombi from myocardial infarctions, valvular disease, left heart failure, endocarditis, and dysrhythmias. But you're going to see that with emboli, you're going to be looking for this dislodged thrombus, an air bubble, amniotic fluid, bacteria, cancer cells, or foreign substances. So, peripheral vascular disease, there's peripheral arterial disease. It's the presence of atherosclerosis distal to the arch of the aorta. It's more common in men in their 60s, 70s that cigarette smoke or diabetes. Symptoms are gradual. Primary symptom is intermittent claudication. Then we have thromboangiitis obliterans or Buerger's disease. It's characterized by the formation of thrombi filled with inflammatory and immune cells. Thrombi become organized and fibrotic and result in permanent occlusion and obliteration of a portion of small and medium-sized arteries in the feet and sometimes the hands. It causes pain, tenderness in the affected area. It is associated with smoking, men in their ages of 25 to 40, and is considered autoimmune. Then we have Raynaud's phenomenon. Raynaud is a vasospasm that occurs with varying frequency and severity and causes pallor, numbness, and the sensation of coldness in the digits. Skin can appear cyanotic. You want to avoid triggers such as cold temperatures and emotional stress. Calcium, and it's treated with calcium channel blockers, nitric oxide agonists, alpha blockers, prostaglandin agonists, and endothelial antagonists are administered. Symptoms are caused by slow, sluggish blood flow, can often lead to gangrenous lesions and amputations. It's mainly in young women. It's primarily unknown origin, and it can be related to a malignancy or pulmonary hypertension, chemotherapy, hypothyroid, or thoracic outlet syndrome. So arterial sclerosis is a chronic disease of the arterial system. It's abnormal thickening and hardening of the vessel walls. It's thickening and hardening caused by accumulation of lipid-laden macrophages in the arterial walls. It's a leading cause of coronary artery disease, stroke, and peripheral artery disease. There's 3 types of lesions associated with atherosclerosis. There's fatty streaks, the accumulation of lipid-laden macrophages that called foam cells. The macrophages have attempted to destroy fatty material and have become filled with lipids, which is why they appear as foam. There's fibrous arthromatous plaque, basic lesions, accumulation of intra-extracellular lipids, proliferation of vascular smooth muscles, formation of scar tissue, and calcifications. Complicated lesion is plaque that's already ruptured. So injured epithelial cells become inflamed. Inflammation plays a fundamental role in the mediation and the steps in the initiation and progression of atherogenesis. Inflamed endothelial cells cannot make normal amounts of antithrombic and vasodilating cytokinase. The next step in atherogenesis occurs when inflamed endothelial cells express adhesions molecules that bind macrophages and other inflammatory and immune cells. Macrophages are active by binding to damaged associated molecular patterns, release from injured cells, and release inflammatory cytokinase and enzymes that further injure the vessel wall. Toxic oxygen-free radicals generated by the inflammatory process cause oxygenation of LDL that has accumulated in the vessel intimia, hyperlipidemia, diabetes, smoking, hypertension contribute to LDL oxygenation and its accumulation in the vessel wall. When the macrophages produce a fatty streak, macrophages also release growth factor that stimulates muscle cell proliferation, and then a fibrous plaque is formed. After the plaque ruptures, we have a complicated plaque. Risk factors include, like I said before, diabetes, smoking, hyperlipidemia, and hypertension. And then it's going to result in inadequate perfusion, ischemia, and necrosis. So any vascular disorder that narrows and occludes the coronary arteries leads to myocardial ischemia. Atherosclerosis is the most common cause. There's two types. There's acute coronary syndrome, which is from infarct, irreversible myocardial damage due to plaque formation. There's chronic, which is ischemic heart disease, which is atherosclerotic or vasospastic obstruction of the coronary arteries. Plaque distribution and thrombus formation. So you can have stable plaques, which obstruct blood flow but are fixed. Unstable plaques are vulnerable. They can rupture and cause platelet adhesion and thrombus formation at any time. So your non-modifiable risk factors for coronary artery disease include increased age, family history, male gender, or female gender if you're postmenopausal. Modifiable is your dyslipidemia, hypertension, cigarette smoking, diabetes, obesity, sedentary lifestyle, and atherogenic diet. So your acute coronary syndromes is unstable angina to a myocardial infarction. So MI is death of myocardium from a sudden blockage of coronary artery blood flow. This may be caused by atherosclerosis, thrombus, or vasospasm. In most cases, tears in the plaque build up associated with atherosclerosis, trigger platelet aggregation, and cause a thrombus to form. As a result of the occlusion of the myocardial, oxygen supply cannot meet the body's demands for oxygenation. Coronary artery disease is the leading cause of death in the U.S., and death is usually resulted from cardiac damage after an MI. You can have asymptomatic MI, which most clinical manifestations are present, and is unstable angina, pressure, tightness in the arms, shoulder, neck, teeth, jaw, abdomen, or back, and radiates to other locations. Fatigue, nausea, vomiting, shortness of breath, coughing, diaphoresis, indigestion, elevation in cardiac biomarkers, EKG changes, dysrhythmias, anxiety, syncope, and dizziness. Myoglobulin is an oxygen-carrying protein similar to hemoglobin that is normally present in the cardiac and skeletal muscle. It is a small molecule that is released quickly from infarcted myocardial tissue and becomes elevated within 1 hour after a myocardial cell death, with the peak levels reaching between 4 to 8 hours. So this is one of the markers that we're looking for, because myoglobin is present. Both cardiac and skeletal muscle is not cardiac specific. The other serum cardiac marker that we look for is creatinine kinase, formerly called creatinine phosphokinase, is an intracellular enzyme found in muscle cells. Muscles include cardiac muscles used adenosine triphosphate as their energy source, creatinine, which serves as a storage form of energy in muscle uses. CK to convert ADP to ATP. So CK exceeds normal range within 48 hours of a myocardial injury and declines to normal within 2 to 3 days. There are 3 isoenzymes of CK, with the MB isoenzyme being highly specific for injury in myocardial tissues. The troponin complex consists of 3 subunits: troponin C, troponin 1, and troponin T, that regulate calcium-mediated contractile processes in striated muscle. These subunits are released during myocardial infarction. Cardiac muscle forms of both troponin T and troponin IR1 are used in diagnosis of myocardial infarction. Troponin 1 raises slowly that myoglobulin and may be useful in diagnosis of infarction, even up to 3 to 4 days after the event. It is thought that cardiac troponin assays are more capable of detecting episodes of myocardial infarction in which cell damage is below that detected of a CK-MB level. Also, we're going to see an EKG, and it's going to have ST segment elevation, and we're going to usually see an inverted Q wave. But the elevation of the ST segment usually is indicative of an acute myocardial injury. And we'll see a prolonged Q wave and an inversion of a T wave. I think I said inversion of Q wave. I meant T wave, sorry. So, unstable angina, or NSTEMI. So we're talking about reversible myocardial ischemia. It's similar with different severity. They differ primarily whether the ischemia is severe enough to cause myocardial damage to release detectable quantities of serum cardiac markers. Persons with negative markers have unstable angina. It has been said that cocaine has been implicated in the risk factor for unstable angina. The diagnosis of unstable angina is based on pain, severity, presenting symptoms, hemodynamic stability, EC findings, and ECG findings, and serum cardiac markers. If positive markers for myocardial injury, they are diagnosed with NSTEMI. Unstable angina is 3 presenting symptoms at rest, usually prolonged greater than 20 minutes. It's a new onset, less than 2 months, exertional angina as evidenced by an increase in severity at the level of one of the CCSC classes to be at least CCSC class 3, or a recent acceleration of angina to at least CCSC class 3. Most cases of unstable angina are caused by significant coronary heart disease. Classic angina and variant angina may progress to unstable angina. So STEMI is cellular injury and cellular death. The primary biochemical consequence is the conversion of aerobic to anaerobic metabolism with inadequate production of energy to sustain normal cardiac function. Irreversible myocardial cell death occurs within 20 to 40 minutes of severe ischemia. You'll see acute ST elevation, myocardial infarction, most severe form of a heart attack, characterized by ischemic death of myocardial tissue. Risk factors include atherosclerotic disease of coronary arteries. Manifestations: sudden severe chest pain, may radiate, nausea, vomiting, diaphoresis, dyspnea. Complications include sudden cardiac arrest due to ischemia, left ventricular dysfunction, and electrical instability. They may have sudden death, especially fatal arrhythmia, if it's not treated within an hour of symptoms. So treatment is to reperfuse with as soon as possible to prevent cardiac cell death. So myocardial ischemia occurs when the ability of the coronary artery to supply blood is inadequate to meet the metabolic demands of the heart. Its most common cause of limitation to blood flow is atherosclerosis. There are three types. There's chronic stable angina. The pain is described as clenching a fist over the left sternal border. The discomfort may be mistaken for indigestion. The pain is caused by the buildup of lactic acid and abnormal stretching of the ischemic myocardium that irritates myocardial nerve fibers. Diagnosis is based on HPI, risk factors, ECG, echo, CT, cardiac, MRI. Script is usually symptom reduction and prevention of MI. The silent myocardial ischemia can occur with the absence of agonal pain, and occurrence of painless episode is unclear. Variant angina is the Prinzmetal angina, is chest pain attributed to transient ischemia of the myocardium that occurs unpredictably and often at rest. Pain is caused by coronary arterial spasm. Disorders of the heart wall include acute pericarditis, pericardial effusion, tamponade, and constrictive pericarditis. So acute pericarditis is acute inflammatory process of the pericardium. Acute pericarditis can be classified according to the cause: infection, trauma, viral, connective tissue disorders such as SLE or RA, uremia, radiation, trauma, drug toxicity. It's defined as signs and symptoms resulting in pericardial inflammation less than 2 weeks duration associated with capillary permeability. Clinical manifestations include the triad of CP, pericardial friction rub, ECG changes. Pain is usually sharp and abrupt, worse with deep breathing and coughing. Diagnosis is PE, ECG, chest x-ray, echo, and treatment depends on the cause. So pericardial effusion and cardiac tamponade. Pericardial effusion refers to the accumulation of fluid in the pericardial cavity. It may be due to injury, inflammation, or arterial capillary filtration pressures. The amount of the fluid and the rapidity with which it accumulates and the elasticity of the pericardium determines the effect of the effusion has on the cardiac function. May have little or no symptoms. The seriousness actually leads to is when we start talking about, can lead to cardiac tamponade is life-threatening condition from bleeding into the pericardial sac. It can occur as a result of conditions such as trauma, cardiac surgery, cancer, uremia, and cardiac rupture due to myocardial infarction. Pulsus paradoxus, which refers to an exaggeration of normal 2 to 4 millimeter Hg decreases in systolic blood pressure that occurs during inspiration, is clinical indication of cardiac tamponade. The seriousness of cardiac tamponade results from the increase of intracardiac pressure, progressive stroke volume, and cardiac output. Constrictive pericarditis. Constrictive pericarditis is a fibrous scar tissue develops between the visceral and the parietal layers of the serum pericardium. Scar tissue contracts and interferes with the diastolic filling of the heart, at which point cardiac output and cardiac reserve becomes fixed. Ascites is a prominent early finding and may be accompanied by pedal edema, dyspnea, and exertion and fatigue. When you're looking at a patient, they're going to have jugular veins that are distended, and they'll have this Kussmaul sign, which is an inspiratory distension of the jugular veins caused by the inability of the right atrium, encased in its rigid pericardium, to accommodate for the increase in the venous return that occurs with inspiration. Sorry about that, guys. Disorders of the myocardium. Cardiomyopathies may be mechanical or electrical. Dilated cardiomyopathies are characterized by progressive cardiac hypertrophy and dilatation and impaired pumping ability of one or both ventricles. Although all 4 chambers of the heart are affected, the ventricles are more dilated than the atria. It may be due to infectious myocarditis, alcohol and toxic agents, metabolic influences, neuromuscular diseases, and immunologic disorders. Hypertrophic cardiomyopathy is characterized by left, right, or left and right ventricular hypertrophy and abnormal diastolic filling. Although the hypertrophy may be symmetric, the involvement of the ventricular septum often is disproportionate, producing intermittent left ventricular outflow obstruction. Diseases of young adulthood. Cause of this disorder is unknown, but often is of familial origin, being inherited as an autosomal dominant trait. Restrictive cardiomyopathies is the least common. Ventricular filling is restrictive because of the excessive rigidity of the ventricular wall, although the contractile properties of the heart remain relatively normal. It is endemic it's endemic in Africa, India, South and Central America, and Asia. Most common causes of endocardial infiltration, such as amyloidosis. It's also symptomatic. Its symptoms is dyspnea, paroxysmal nocturnal dyspnea, orthopneic orthopnea, peripheral edema, ascites, fatigue, and weakness. Sorry, I get to talking too fast, don't I? Now we're talking about disorders of the endocardium. So mitral valve stenosis represents the incomplete opening of the mitral valve during dystole with the left atrial distension and impaired filling of the left ventricle. Most commonly is the result of rheumatic fever. Less frequently, it is congenital. Mitral valve stenosis is continuous, progressive, lifelong disorder consisting of a slow, stable course in the early years and progressive acceleration in the later years. The 10-year survival rate for persons with untreated mitral stenosis is 50 to depending on symptoms, is characterized by fibrous replacement of the valvular tissue along with stiffness and fusion of the valvular apparatus. Symptoms related to elevation of the left atrial pressure and pulmonary congestion, decreases cardiac output, owing to impaired left ventricular filling and left atrial enlargement with development of atrial arrhythmias and mural thrombi. Mitral valve regurgitation is characterized by incomplete closure of the mitral valve with the left ventricular stroke volume being divided between the forward stroke volume that moves into the aorta and the regurgent stroke volume that moves back into the left atrium during systole. It can result from rheumatic heart disease, rupture of the chordae tendineae, or papillary muscles, papillary muscular dysfunction, or stretching of the valve structure due to dilatation of the left ventricle or valve orifice. Mitral valve prolapse leads to regurgitation. Characteristic features of mitral valve regurgitation is enlarged left ventricle, a hyperdynamic left ventricle impulse, and a pansystolic murmur. Treatment may be surgery. Mitral valve prolapse occurs in 2 to 6% of the population, seen more frequently in women than in men, but has a familial basis. Causes unknown, associated with Marfan's, osteogenesis imperfecta, and other connective tissue disorders. Pathologic findings in persons with mitral valve prolapse include myxedematus. They need to check for thyroid. They need to check a thyroid panel. Most symptoms are caught during a routine physical. Aortic stenosis is characterized by increased resistance to ejection of blood from the left ventricle into the aorta. Because of the increased resistance, the blood demand on the left ventricle is increased and the volume of the blood ejected into the systemic circulation is decreased. Most common cause of rheumatic fever, people tend to be asymptomatic and may need aortic valve replacement. Aortic valve regurgitation is the result of an incomplete aortic valve that allows blood to flow back into the left ventricle during diastole. As a result, the left ventricle must increase its stroke volume to include blood entering and leaving the lung. Rheumatic fever is first on the list, and we hope we don't. We hope to not get this, and we want to know if a patient is having any symptoms of this, so we can get them treated right away. Ineffective endocarditis is life-threatening, infectious of the inner surface of the heart, leading to formation of bulky, friable, vegetative, and destruction of the underlying cardiac tissue. For ineffective endocarditis to develop, we need 2 dependent factors normally are required, and that is damage of the endocardial surface and a portal of entry by which the organism gains access to the circulatory system. The pathophysiology of infective endocarditis involves the formation of the intracardiac vegetative lesions that have local and distant systemic effects. The vegetative lesions that are characteristic of infective endocarditis consist of collection of infectious organisms and cellular debris enmeshed in the fibrin strands of clotted blood. These lesions may be singular or multiple, and then they form emboli. Typical agents are bacteria, Staphylococcus aureus cause, viruses, fungi, rickettsia, and parasites. So our most common sites, I think I said, were the aorta and the mitral valve are our most common sites. Diagnosis can be through blood cultures and is the most definitive diagnostic procedure and is essential to guide treatment for this. Manifestations, classic findings is fever, new or changed cardiac murmur, petechial lesions of the skin, conjunctiva, and oral mucosa. Some characteristic physical findings, they can get these Osler nodules or painful erythemic nodules on the pads of their fingers and toes, or Janeway lesions, which are non-painful hemorrhagic lesions on the palms and soles. Other is weight loss, back pain, night sweats, and heart failure. Treatment is, we want to treat the infective endocarditis and focuses on identifying and eliminating the causative microorganism, minimizing the residual cardiac effects, and treating the pathological effects of the emboli. Antibiotic therapy is used. Surgery may be indicated for moderate to severe heart failure, progressive renal failure, significant emboli, dysrhythmias, or left-sided endocarditis. Infected prostatic valves may need to be replaced. But we want to prevent this, so we want to practice prevention. That's why we do a lot of times treat them before they have dental procedures. Rheumatic heart disease is an immune-mediated multi-system inflammatory disease that follows a group A beta hemolytic streptococcal throat infection. It can cause chronic valvular disease in the mitral or aortic valve typically. It usually follows having strep throat infection by 1 to 4 weeks. Is manifested by having a sore throat, headache, fever, abdominal pain, nausea, vomiting, swollen glands, erythema, marginatum, and subcutaneous nodules. Diagnosis is usually made from 2 major signs and 1 minor sign, or 2 majors and 1 major and 2 minors. So what I'm talking about there is the Jones criteria. The criteria were developed because no single laboratory test or sign or symptom is pathogenic of the disease, although several combinations of them are diagnostic. The signs and symptoms of rheumatic fever are grouped into major and minor categories. So the presence of 2 major signs, carditis, polyarthritis, chorea, erythema, marginatum, and subcutaneous nodules, are 1 major, and 2 minors are arthralgia, fever, elevated level of acute phase reactants, and prolonged PR interval, accompanied by evidence of preceding group B strep infection, indicates a high probability of rheumatic fever and heart disease. So dysrhythmias or arrhythmias are related to alterations in autonomic excitability, conductivity, refractoriness, or specialized cells in the conduction system of the heart. It ranges from occasional missed or rapid beats to severe disturbances that affect the pumping ability of the heart. Examples: premature atrial contractions, flutter, fibrillation, premature ventricular contractions, bradycardia, tachycardia, asystole. It's diagnosed by ECG, Holter monitor, exercise stress test, electrophysiology studies. Treatment can be pharmacological treatment, antidysrhythmic drugs, electrical interventions, pacemaker ablations, and surgical interventions. Heart failure. The inability of the heart to maintain sufficient cardiac output to support the bodily functions, recruitment of compensatory mechanisms designed to maintain the cardiac reserve. Types of heart failure. There's left heart failure, right heart failure, and high output heart failure. So heart failure is defined with the reduction of ejection fraction, or systolic heart failure is defined as an ejection fraction of less than 40%, and in the ability of the heart to generate an adequate cardiac output to perfuse vital tissues. The compensatory mechanisms of the heart failure is the cardiac reserve is largely maintained through compensatory mechanisms. The length and the tension is the Frank-Starling mechanism states that the stroke volume of the heart increases in response to an increase in the volume of the blood filling the heart in the end diastolic volume when all other factors remain constant. So then we have the sympathetic nervous system, the renin-angiotensin aldosterone mechanism, and the natriuretic peptides, the endothelial proteins that constrict blood vessels and raise blood pressure. And we have myocardial hypertrophy, remodeling, and manifestations of heart failure, myocardial hypertrophy and remodeling. So when we're talking left-sided heart failure, we have systolic heart failure, which is the inability of the heart to generate adequate cardiac output to perfuse tissues, ventricular remodeling, and causes included myocardial infarction, myocarditis, and myopathy. Diastolic heart failure is pulmonary congestion despite normal stroke volume and cardiac output. Causes include myocardial hypertension, ischemia, diabetes, valvular, and pericardial diseases. So we have manifestations of left heart failure is the result of pulmonary vascular congestion and inadequate perfusion of the systemic circulation. It includes dyspnea, orthopnea, cough, a frothy sputum, fatigue, decreased urinary output, and edema. Physical examination often reveals pulmonary edema, cyanosis, inspiratory crackles, pleural effusion, hypotension, hypertension, and a S3 gallop, and evidence of underlying CAD and hypertension. Manifestations of heart failure. Manifestations of heart failure include fluid retention, edema, respiratory manifestations, fatigue, weakness, and mental confusion. Malnutrition, cyanosis, arrhythmia, and sudden cardiac death. They can have acute pulmonary edema, capillary fluid moves from the alveoli of the lungs, becomes stiffer, harder to inhale, less gas exchange in the alveoli, crackles, frothy pink sputum, hemoglobin is not completely oxygenated. And those can be symptoms of all of them. Right heart failure, most commonly caused by diffuse hypoxic pulmonary disease, can result from increase in left ventricular filling pressure that is reflected back to the pulmonary circulation. Is defined as the inability of the right ventricle to provide adequate blood flow into the pulmonary circulation at normal central venous pressure. High output failure is the inability of the heart to supply the body with blood-borne nutrients despite adequate blood volume and normal or elevated myocardial contractility. Causes include anemia, hyperthyroidism, septicemia, and beriberi. Shock. Cardiovascular system fails to perfuse the tissue adequately, leads to impaired cellular metabolism, impaired oxygen use, impaired glucose use, results from hypoperfusion of organs and tissues, It causes production, the release of the inflammatory mediators that further comprise perfusion. It decreased energy supplies lead to poor cellular function. Its compensatory mechanisms include CNS activation, increased heart rate, peripheral vasoconstriction, relaxation of the bronchioles. In the renin release, then the increase in angiotensin II, which augments vasoconstriction and increased water retention. Manifestations vary based on the stage, but often include hypotension, tachycardia, increased respiratory rate. Types of shock, there's cardiogenic, which is failure of the heart to pump blood adequately. That's usually due to an MI. There's hypovolemic, is characterized by diminished blood volume, such that there is inadequate filling of the vascular compartment. That's hemorrhagic. Neurogenic is caused by, that's due to a hemorrhage, neurogenic is caused by decreased sympathetic controls of blood vessels tone due to defect in the vasomotor center in the brainstem or the systemic outflow to blood vessels. Anaphylactic is characteristic by massive vasodilation, pooling of the blood in the peripheral blood vessels, and increased capillary permeability. This is usually due to a hypersensitivity reaction. Systemic is association with severe infections and systemic response to infections such as bacteremia. Complications of shock: acute respiratory distress syndrome, renal disease, disseminated intravascular coagulation, cerebral hypoxia, and death. It's diagnosed by CBC, Coulter's coagulation studies, cardiac biomarkers, arterial blood gases, chest x-ray, hemodynamic monitoring, EKG, and echocardiogram. Management of shock includes the identification and treatment of underlying causes, and maintaining respiratory status, cardiac monitoring, and rapid fluid replacement. And we are done, ladies and gentlemen. Thank you.